Good evening. My name is Simon Marr. I'm an obstetrician gynecologist from Melbourne. Many thanks for the invitation to be part of this early pregnancy care webinar. Thanks to our sponsor, Samsung, and apologies to Ligita, Maya, and Ilan that I can't be with you this evening in person. My talk, which I'll be covering, is on the classification, diagnosis, and differential diagnosis of ectopic pregnancy. So I'll not be focusing on management, but rather a sonographic approach and clues to diagnosis and differential diagnosis when faced with this common and rare forms of ectopic pregnancy. So I'll start my talk now. Management of ectopic pregnancy. The talk is divided into the following sections: an introduction focusing on tubal ectopic pregnancy, and then the rarer forms of ectopic pregnancy, and finishing up with some summary and comments. If we look at the ESHRA classifications of ectopic pregnancies, you will note there are 15 different types of ectopics, 13 involving the uterus and tubes, and 2 involving the ovaries or intra-abdominal ectopics. You will note for the ESHRA classification, almost all ectopic pregnancies now include 3D evaluation, and this is instrumental in identifying the exact location and characteristics of an ectopic pregnancy, and therefore I will pay homage to not just 2D, but 3D evaluation of these pregnancies. If you look graphically at ectopic pregnancies, they can be divided into this group of 9, and I will go through these one by one, but I find that the graphics of the location of both the intrauterine pregnancies, lateral ectopic, and other ectopic pregnancies is very helpful when you understand the graphics in my description comparing to the sonographic findings. I'll start with the most common ampullary ectopic pregnancy. When we look at these, they represent about 80% of ectopic pregnancies in the fallopian tube, the most common site. When we look at these, we frequently will have a history of pain, bleeding, and amenorrhea. On ultrasound, we look for the findings of an adnexal mass, gestation sac, and about 10 to 15% of them will have a live embryo necessitating surgical intervention, and therefore very important to determine whether there is heart motion present. And then look for blood in the pouch of Douglas, which doesn't always necessarily mean that there's rupture. It may be leakage from the fimbral end of the fallopian tube. So let's go through these. As you sweep from right to left, you see in a mid-sagittal section, the uterine cavity is empty in a patient with pain and PV bleeding. As we sweep out to the ovary, we then appreciate there is a soft tissue mass sitting immediately adjacent to the ovary. We take the same patient and acquire a 3D volume, and the point I will make in this 3D volume, it is far easier to appreciate the trophoblast ring and surrounding tubal edema on 3D with volume contrast imaging and volume speckle reduction imaging. 3D, in fact, becomes a very powerful tool in distinguishing the exact location of trophoblast, and I will make reference to this throughout the talk today. Compare the trophoblast ring here on 2D, which is indistinct, and clear, which it is here demonstrated on 3D evaluation. So 3D doesn't always necessarily mean rendering, as is demonstrated here. This is taking a volume of the ectopic pregnancy and then demonstrating the internal ecotexture of the gestation sac using 3D technologies. When we rotate on this around the y-axis, we can see it's not actually spherical, but rather it is a disc-like structure. Not surprising, considered it is compressed by the fallopian tube. However, let's go to a far more subtle case where the HCG is only 250 units with a left iliac fossa pain and PV bleeding. You can see the blood within the uterine cavity. There's no gestation sac. There's no evidence of retained products of conception. When you look at the adnexia, you see the ovary coming into view here, but there is a very subtle, indistinct soft tissue mass that sits beside the ovary just here. You could easily pass this as being bowel. However, when you take a 3D volume of this area, you will begin to appreciate that you are looking at an ampullary ectopic pregnancy. Again, you would go to 3D with VCI static, and here, as you translate through the volume, you begin to see that this is the ovary with follicular development, and this tissue here is all trophoblast, and this here is tubal edema. The power of 3D with volume contrast imaging And with volume speculum reduction imaging allows us to distinguish the hyperechogenic trophoblast from the tubal edema. Remember, it's the trophoblast that's the aggressor. How much trophoblast is, the more likely it is that it is going to rupture. Not only in terms of determining the volume of trophoblast in terms of the possibility or likelihood of rupture, it also allows you to clarify these complex ectopics. When you sweep out to the pelvic side wall, you see gross enlargement and edematous fallopian tube. It's hard to work out exactly what is going on in this patient. However, when you then take a 3D volume and this patient is 8 weeks and 3 days of gestation with pain, bleeding, and slowly rising HCG, you now begin to appreciate that there are in fact 3 gestation sacs. In fact, this is a trichorionic triplet ectopic pregnancy in a fallopian tube. Again, this only became possible to realize this on a 3D volume acquisition. Let's move to the interstitial ectopic pregnancies, and these can be particularly challenging because they maybe mimic the appearance of a lateral intrauterine gestation or a lateral ectopic pregnancy, which I'll come to talk about in a second. The interstitial may be divided into partial interstitial or complete interstitial, and then I'll talk about the isthmic tubal ectopics afterwards. So, when you look at this axial section, and it's the most important section because you look at an axial section at the uterine cavity, and you here see the gestation sac, embryo, and yolk sac, but you can see there's a band of muscle tissue separating the uterine cavity from the ectopic pregnancy, which is positioned in the interstitial portion of the fallopian tube. This is a complete interstitial ectopic pregnancy. When you look on 3D on the same axial section, you can measure the distance between the outer rim of the trophoblast and the outer edge of the uterine cavity. It becomes far more impressive, however, when you look on 3D coronal section. Here's your triangular uterine cavity, which is empty, no blood, no gestation sac, no retained products. But here you have your complete interstitial ectopic pregnancy separated by a band of muscle tissue. The partial interstitial ectopic pregnancy, however, is much more challenging because you see now the ectopic abuts the uterine cavity at the fundus towards the left tubal ostia, and you can appreciate that as you sweep through this on 3D evaluation. Now you can see on 3D in a coronal section that here you have the continuity of the uterine cavity with the trophoblast tissue, making this a partial interstitial ectopic pregnancy. Once you reach on these two images, that communication with the cavity brings us to that classification of a partial interstitial. Then moving further along the fallopian tube is the isthmus tubal ectopic pregnancy. In this case, there is no surrounding myometrium, unlike the partial and the complete interstitial, which I've just described. As you sweep through this in the coronal section, you see this is a heterotopic pregnancy. There is an intrauterine gestation, but there's also an ectopic pregnancy in the interstitial portion of the fallopian tube in a patient that's 8 weeks and 1 day of gestation. You can see the ectopic is significantly smaller gestation sac and embryo when compared to the intrauterine, which is the norm. Let's move on to the eccentric intrauterine ectopic pregnancy because these are the eccentric intrauterine pregnancy because these are the pregnancies which mimic the appearances of the interstitial, particularly the partial interstitial. If you look at the eutopic pregnancies, there are really 2 types that concern us. There's the lateral eutopic, which we used to previously call eccentric intrauterine pregnancies, or the low eutopics, which are positioned low within the uterine cavity, which may mimic the appearance of a cervical ectopic pregnancy, or indeed a cesarean scar pregnancy in a patient who's had a previous cesarean section. With regard to the ESHRE guidelines, it shows this triangular appearance to the uterine cavity. However, we all know that in many instances the uterine cavity is not triangular, and if you have a pregnancy positioned up in this area here towards the right tubal ostia, or in this case towards the left tubal ostia, or in this case towards the right tubal ostia, or in this case in the left tubal ostia, all of these mimic the appearances of an interstitial ectopic pregnancy. You have to work out whether in fact it's lateral eutopic or whether it's partial interstitial ectopic pregnancy. And it's very important to go through a systematic approach, looking at the patient's symptoms of pain and bleeding, examination findings of tenderness, and scan findings of free blood within the pelvis, and laboratory findings of slowly rising beta HCG or HCG patterns. So it's a combination of all those 4 The history, physical examination, scan findings, and laboratory testing will help you distinguish between the two. I would like to take you through some examples because some can be quite challenging. I don't think any of you would struggle with this. This is a lateral ectopic pregnancy, and with 3D with volume contrast imaging, you can see here the trophoblast ring, which is entirely enveloped by the surrounding decidua. This is a lateral ectopic pregnancy. It is not interstitial. This may be more challenging. On sagittal imaging, there's nothing really to appreciate. It looks like a straightforward intrauterine gestation. However, when you come around to looking at this on a 3D coronal image, you can appreciate how you may mistake this as being a partial interstitial ectopic pregnancy. But in fact, this is a normal lateral ectopic pregnancy in a cavity that is not triangular. We do not use the term for this as being an angular ectopic. We do not use the term coronal ectopic. It is not interstitial. It is lateral ectopic. In this case here, it can be a little bit more challenging as you come across on this. Let me actually show you the 2D. So this is the uterine cavity here, which comes up and just about envelops the gestation sac. This is the trophoblast ring. This is the decidua. It can be hard to appreciate the decidua going all the way around the gestation sac. And this is where 3D comes in, because you can follow the line of the decidua and the interface between the decidua and myometrium and realize that this is enveloped. It would be so easy to mistake this diagnosis as being an interstitial ectopic pregnancy, either partial or indeed complete, in the hands of the inexperienced. This is not angular, this is not interstitial, this is not cornual, cornual referring to presence of an ectopic pregnancy in a redundant horn, but rather this is a lateral ectopic pregnancy. Other cases may be challenging. In this case here, you see a gestation sac funnily within the uterine cavity, and as you follow the trophoblast ring all the way out to the right tuberosity, you can appreciate that it comes really a very subtle bulge of the uterine cavity, and here you can see this subtle bulge of the uterine cavity in another case. But all of these are lateral ectopic pregnancy. Now let's move on to some of the rarer forms of ectopic pregnancy, which is an intramural ectopic pregnancy and a pregnancy in a redundant horn. So in this case, you sweep across the uterus and you see a gestation sac located here within the muscle. From there, you move on to a 3D volume and see the uterine cavity, and you can appreciate that there is a gestation sac, a yolk sac, and an embryo located within the myometrium. This shows here a 3D rendered image using HD Live, showing this is an intramural gestation sac here and an empty uterine cavity. This typically happens in patients who've had a previous uterine perforation, previous myometry, or previous classical cesarean section. And a partial intramural, as you sweep across this in the coronal section, you can appreciate the trophoblast ring communicating with the decidua, in a sense similar to the partial interstitial ectopic pregnancy. And this is referred to as a partial intramural ectopic pregnancy. As you come across, you see the trophoblast ring, but follow it, and you see that that communicates with the decidua. Then we talk about the ectopic pregnancy that occur in a rudimentary horn. It may be a horn that's fused or a horn that's separate. So if we look at this here, diagrammatically here we have a rudimentary horn containing an ectopic pregnancy, and surgically this is the fallopian tube coming out of the main uterine body, and this is the fallopian tube here connected to the ectopic pregnancy in a redundant horn. These are extremely challenging diagnoses. If we look diagrammatically in the top left-hand corner, this is non-communicating. It is separate. So we look here in this gestation sac here, we see an embryo, a yolk sac, and the limb buds. As we sweep across the uterine body and pregnancy disappears, and we come across to the midline, and now the cervix comes into view, and here we have the uterine body. Again, to distinguish that the cervix is not actually connected to this gestation sac, to this uterine body, can be extremely challenging. And in a sense, the importance of looking not only on sagittal imaging of a pregnancy, but also screening in the cervix to fundus view, in which you may appreciate that the uterine body is entirely separate from the ectopic pregnancy in the redundant uterine horn. Difficult diagnosis, frequently missed on ultrasound, and complicated with rupture and hemorrhage and bleeding. We next move to cesarean scar ectopic pregnancy, and there are different classification systems for this. I'm going to stick with ESHRE and the partial and complete types of scar ectopic pregnancy, and then I will talk about low implantation or the low U topics. For many of these ectopics, they occur in a pre-existing niche, and this is an example of a retroverted uterus with a striking niche here, 3D representation of the same niche demonstrated in the bottom left-hand corner. If we look at the ESHRE classification, whether it's on the scar, in the scar, or through the scar, and matching sonographic examples in the three images, or three cine loops, are demonstrated below. Of course, the ones that you worry most about are those that bulge out towards the urinary bladder. The earlier they are, the easier they are to treat. The larger gestation sac size is, the more bulge into the urinary bladder. The later in gestation, the harder they are to treat. There are different classification systems that then just been recently published, which Ilan will maybe talk about, is another type of classification, type 1 and type 2, depending on whether there's less or greater than 50% protrusion into the uterine cavity. And this article is very well worthwhile a read, with many co-authors, including Davor Djokovic, with a large series of scar ectopic pregnancies. This is beyond the scope of my talk today. I will, however, go through examples of it. This is a patient, when you go back to this image, you'll see she has Crohn's disease with multiple laparotomies as a colostomy and severe abdominal adhesions, an IVF pregnancy, sadly ending up as a scar ectopic pregnancy. So in our past history, having had a previous cesarean delivery. So as you scan through this, you see signs of the pregnancy, which is outside the uterine cavity. So this is the uterine cavity here. And this is where the pregnancy is entirely within the cesarean section scar. Patient present with vaginal bleeding and pain at 6 weeks and 3 days of gestation. Do not make the assumption what you're seeing here, the fluid is blood, particularly in a patient with a history of Crohn's disease and multiple surgeries. This is likely to be peritoneal inclusion cysts and fluid related to past surgery. Again, with 3D, we can distinguish the surrounding trophoblast, and this here is the cavity lying with the pregnancy entirely within the scar. But picking them up much earlier than this is an advantage because they are so much more treatable when they are so small. This is a very early ectopic pregnancy situated within the cesarean section scar with no bulge or extension into the uterine cavity. And another one here in the cesarean section scar, and follow the line of the cavity. You can see it sliding off here. This is entirely within the scar. These are all examples of complete cesarean scar pregnancies. If we look in this case here, we can see that this extends down inferiorly into the uterine cavity on 2D imaging and on 3D imaging. So this is a partial cesarean scar pregnancy. Again, Ilan will make the point not to call it cesarean scar ectopic, but rather cesarean scar pregnancy. Then you have the low implantation or the low utopic pregnancies. So this is a 3D evaluation of the uterine cavity where you see the gestation positioned low within the cavity, and here similarly low within the uterine cavity. Important in these to recognize that they have a higher chance of miscarriage, and they also have a higher chance of a morbidly adherent placenta. And this is important to make note of in your pregnancy report. Cervical ectopic pregnancies are rare, and many of these, when you look at these, may strike as being cervical ectopic pregnancies, but in fact they are miscarriages in progress. In this case, you can see it conforms with the shape, or gets compressed, I should say, as you sweep through it. And then you can see in a coronal image that spherical appearance of a pregnancy within the cervix. But really you need to push, and as you manually palpate, you see that this slides within the cervical canal. So there may be an embryo present and a heart motion present, but this is really a pregnancy miscarriage in progress. This is a much more sinister appearance of a mid-sagittal section through the cervix showing a gestation sac within the cervical canal. This is the uterine body, the internal os, and the cervix here with the pregnancy entirely within the cervical canal. In this case here, a very old case in the patient who has an empty uterine cavity. And if you look at here, the pregnancy is entirely within the cervical canal, but much later in gestation with a very strong vascular appearance. And remember, if you ever see an IUD in situ and a coexistent pregnancy or possibly a HCG, it's likely to be a coexistent ectopic pregnancy. and in this case here, another partial cervical ectopic pregnancy. I'm going to finish up. I'm slightly over time with the abdominal pregnancies. So this here is an example of an empty uterine cavity. Up here we can see a patient who's at 8 weeks and 2 days of gestation, a dating scan. The beta HCG is at 28,000. As we come up here, we see that there's a typical trophoblast here of a dichorionic twin gestation. And then using 3D with VCI static, we can appreciate that there are two gestation sacs, one smaller than the other in a patient with a primary abdominal ectopic pregnancy. Then there's the abdominal ectopic pregnancy, which are secondary, and these are ectopic pregnancies that are extruded through the fallopian tube. So here we have an extruded ectopic pregnancy here with the gestation sac, yolk sac, and embryo, and another one here sitting in the pouch of Douglas. These were not primarily fertilization taking place in the abdominal cavity, but rather in the tube and being secondarily extruded. And lastly, and not least, is the ovarian ectopic pregnancy. This is a sweep comparing both left and right pelvic sidewall. This is the ovary on view on this side and the right, and then sweep across. You can compare to the opposite side. You can see a gross enlargement of the left ovary in a patient with a HCG of 80,000. And you can compare the size of the ovary indeed to the size of the uterus and realize the gross enlargement of the ovary in this case. When you look at the texture of the ovary, it's got a very abnormal appearance, but when you apply 3D VCI static, you can appreciate that this is all trophoblast and this is the edematous ovary. But it's color that's so striking when you see it lights up like a Christmas tree. And these are the surgical findings demonstrating a normal left ovary, normal fallopian tube, and then over to the ovary on the opposite side. You can see why these ovaries bleed so much when they rupture later. So I've covered in summary the different types of ectopic pregnancy, both by graphic demonstration and following according to the ESHRE guidelines. And I ask you the question, what difference does this talk make to you when you go to work tomorrow morning? Well, I think the first thing is it's important to understand the ESHRE classification and ensure that we all use the same terminology. Secondly, that 3D is a very powerful tool, and not so much in terms of rendering, but rather in terms of borders between tissue and aiming to get maximum contrast and understanding what's trophoblast and what's edema, and adopting the 3D technologies to get to that end. I know most ectopic pregnancies are ampullary, but always have in the back of your mind the rare forms of ectopic pregnancy, particularly when you've got high HCG and after repeated scans, no signs of an intrauterine pregnancy. You must think of the rarer causes. Be careful of the low implantation pregnancies because of the high chances of placenta accreta later, and also for those miscarriages in progress, don't make an early and enthusiastic overcall of cervical ectopic pregnancy. I'll stop there. I've gone a little bit over time. Again, thanks very much for your attention and for the opportunity to present here this evening. Bye for now. Good evening. My name is Simon Marr.